very pleasant morning to everyone. I'm so sorry with my voice because I just recovered from my bad sore throat. So anyway, welcome to breakfast at UMHealth. It's a great pleasure to have all of you to join today's session. My name is Dr. Ai Kah from Department of Social and Preventive Medicine. A human right-based approach to end HIV or AIDS promotes equitable healthcare access. Initiative focus on stigma reduction, legal protections, job opportunities, housing, education, and social supports aim to dismantle structural barriers. These building blocks empower affected communities to access essential services while preserving dignity and promoting health equity. Together with me today is nonetheless my dear colleague, my next door neighbor, Dr. Ika Muhammad Salleh. The title of the talk is Take the Right Path, Health and Justice to End AIDS, in conjunction with World AIDS Day in December. Dr. Noor Afiqah is an academician specializing in public health with a particular focus on social and behavioral science. Her research integrates community engagement and implementation science to drive positive social and health outcomes to people who use drugs with a specific focus on HIV, hepatitis C, and drug use. So, welcome, and so please join me in welcoming Dr. Noor Afiqah. Dr. Ika, the stage is yours.
Thank you so much. Thank you, Ai Kah, for the lovely introduction, and thank you everyone for joining today's breakfast at UMHealth. To those who may have tuned in to breakfast at UMHealth last week, you'd probably heard of the 95 goals presented by my colleagues and I. And today's topic is an extension to these goals with a specific focus on this year's World AIDS Day theme, which is Take the Right Path, which places an emphasis on strategies that protect the rights of people at risk for HIV and AIDS. I will start by setting the stage to kind of help us understand what taking the right path really means, followed by some descriptions on social and structural barriers to HIV treatment and prevention services that kind of reflect how rights are oftentimes being violated. And lastly, to offer some final thoughts about what we think about health, equity, and justice. So one key thing that we spoke about last week was the 95 goal, which specifies that by 2030, 95% of all those living with HIV would know their status, and of these 95% of these people who know their status would have their treatment started, and of those people who have started on treatment, 95% of them would have their viral load suppressed, which means at which point the risk of transmitting the virus would be low. What was not mentioned last week really is the 10-10-10 goals on the far left here, as shown on the diagram, which aims to improve the environments in which people live. New 10-10-10 targets state by 2025, which is next year, less than 10% of countries should have punitive legal and policy environments that deny or limit access to services. Less than 10% of people living with HIV and key populations will experience stigma and discrimination, and less than 10% of women, girls, people living with HIV and key populations will experience gender inequality and also violence. And these are ambition targets, and progress will have to be substantial in the next few years. So 4 key areas of decriminalization will be possession of small amount of drugs, criminalization of sex work, same-sex sexual behavior, and also HIV transmission, exposure, or non-disclosure, which I will go through one by one in a minute. So very few countries, as highlighted here on the HIV policy lab map, have partially or fully adopted non-criminalization policies of drug use. So what it means here is that partial adoption would typically mean decriminalization of drug use is limited to specific drugs, specific amounts of drugs, or even specific circumstances, while full adoptions, such as what has been applied in Portugal, reflects this broader public health approach to drug use without punitive measures, meaning that people do not go to prisons, people do not go to compulsory detention centers, but are diverted to treatment or other forms of support. So these policies, be it partial or full, it often facilitate access to harm reduction services, HIV treatment prevention services, and reduce stigma associated with drug use. However, you can see that a large majority of countries in the world, which are highlighted in orange here, maintain strict criminalization policies and oftentimes create significant barriers for people who use drugs to access HIV treatment prevention services. For same-sex sexual activities, over 100 countries have fully adopted policies that decriminalize same-sex sexual activities. And full adoption means that it would eliminate legal penalties and restrictions. And countries with partial adoption, such as in Russia, where enforcement and penalties are minimal, can still be beneficial by reducing fear and stigma that is often associated with seeking health services. And these countries in blue have fully decriminalized HIV disclosure, meaning that individuals living with HIV are not legally obligated to disclose their status to sexual partners or others unless required by public health laws. So in some countries, partial adoption still exists where HIV disclosure laws apply only in specific contexts, for instance, during medical procedures or for criminal prosecution, but not as a general requirement to the general public. However, in numerous countries, failure to disclose HIV status remains decriminalized. And what it does is perpetuating stigma and discouraging people from seeking care or even disclose their status due to the fear of legal repercussions. And common issues with criminalization of HIV disclosure is that intent is often ignored, and in many cases, individuals are persecuted even if they did not intend to harm or transmit virus. And oftentimes, scientific advances are overlooked. Laws are oftentimes failing to acknowledge for scientific advancements, such as the concept of U equals U, undetectable equals to untransmittable, meaning that people who are effectively on treatment cannot transmit the virus. And this is something that people do not really understand, hence why these policies are oftentimes take place. And in terms of sex work here, as you can see here, very few countries have not adopted policies that do not criminalize sex work. And New Zealand is not been seen, it's not seen in the map, but it's the first country to fully decriminalize sex work. And in the Netherlands, sex work is not fully decriminalized, but it's being legalized and regulated under strict conditions. For instance, brothels should obtain permits and workers are subjected to health and safety regulations. Now, with all that being said, the world can end AIDS by 2030 if everyone's rights are upheld and communities take the lead in initiatives that allow people to access these services. And protecting human rights has always been key to progress in the HIV response, which has also advanced the broader right to health and also strengthening healthcare systems. Now, we know that key HIV treatment and prevention services are, for instance, methadone treatment, a needle exchange program, condoms, pre-exposure prophylaxis, antiviral therapy that works as treatment as prevention. These are all key treatment and prevention services that people at risk need to access. And if you're looking at the social and structural factors framework, it presents how laws and policies, the social determinants of health, such as the living conditions and healthcare, can add on to the problems of existing laws that criminalize these different key populations and in turn reduce inequities in health, such as access to care, access to treatment and medication, the risk of more severe disease. Criminalization of sex work, for instance, sex workers, they have 3 times at risk, they are 3 times more likely to experience sexual or physical violence, 2 times as likely to have HIV or another STI, and 1.5 times more likely to engage in sex without condom with clients compared to those who are not engaging in sex work. Other social conditions such as material insecurity, which can also be a measurement of poverty. So compared to other key populations who do not use drugs, people who use drugs had an 83% lower likelihood of presenting good material scores, like having a house to live in, having furniture, having food on the table, or even having the money to pay bills. And we saw how this can translate into poor engagement in HIV treatment and prevention services. For example, homelessness or not being on any form of income assistance were associated with methadone disruption. And in Malaysia, in a study of Malaysian fishermen, work and transportation were the two most frequent obstacles to taking methadone, because daily administration of methadone might not be accessible for fishermen who go on multi-day journeys to the sea. And one major barrier to HIV treatment and prevention services is the fear of arrest and police harassment. In many places, criminalization of drug use are combined with heavy policing near harm reduction sites, which deter people who use drugs from accessing services. For example, what we're seeing in Tijuana, Mexico, researchers found that the fear of police harassment around the needle and syringe programs significantly lowered attendance and service use by people who use drugs. And studies have shown that an increased police presence around methadone clinics have discouraged people from coming to attend these life-saving programs because of fear of being arrested. And stigmatization is also another important component that are, harmful effects of criminalization. Stigmatization contributes to reduce help-seeking behavior, because when individuals are afraid of being judged or marginalized, they are less likely to seek out harm reduction or HIV treatment prevention services. And this, what it does, it really is preventing these interventions from reaching out to people who are in need of these prevention services most, which oftentimes lead to poor health outcomes in marginalized populations. There's also an issue on the interruptions of continuity of care when people are in prisons. People are unable to continue methadone when being incarcerated, and it's even worse for people who are in lockups. It's also disrupting HIV treatment for those who are living with HIV, leading to individuals experiencing higher risks of disease progression and even mortality post-release. I'm going to talk a bit about high threshold programs. So many programs for at-risk populations have high threshold requirements, which impose strict eligibility criteria such as abstinence, right? So meaning that your urine must be clear, you must abstain from using drugs for you to be able to access services. So these criteria often exclude marginalized groups, especially homeless people with and those with unstable lifestyle, and also those who are experiencing drug addiction. So as a result, some of the most vulnerable individuals are denied access to essential HIV treatment and prevention services. For example, in Vancouver, in Canada, high threshold criteria in methadone programs have led to lower retention and even higher dropout rates. And this issue was particularly severe among homeless and unstable individuals who are more likely to need flexible, low threshold options that don't impose such strict requirements. And I would like to kind of draw your attention to the Inspire project, which I am very much lucky to be part of. So the Inspire project is strengthening and amplifying the voices of women and young people affected by punitive drug policies in Southeast Asia. And it's a collaboration between different NGOs in different countries, in Cambodia, in Indonesia, and we've got Persatuan Insamuni representing Malaysia. We've got Ai Kah in Philippines and in Thailand. And it's being coordinated by the International Drug Policy Consortium. So the project aims to do is to empower women and vulnerable youth that are impacted by punitive drug policies, focusing on drug users, formerly incarcerated individuals, and women at risk. So we want to be able to provide a platform for these groups to share their voices and advocate for better drug policies for them. And we've been hearing a lot of stories coming from our participants, coming from people who have joined in the Inspire project. And And some of the case studies that I would like to share with you, for instance, women who use drugs, the impact of criminal record has so much harmful effects on the way they assess treatment. So these quotes are in Malay, but I can provide some key points from this quote. So one of them was saying, in terms of job, kalau bab kerja, kalau ada record, which means criminal record, orang senang dibodohkan. Saya berapa kali kerja tak dapat gaji, kerja guard berapa bulan tak dapat gaji, rumah sewa tak bayar lagi, motor saya rosak, saya ada sijil, saya belajar tinggi juga, tapi tak guna. Saya kerja kilang, kerja dah elok, pegawai check record. So people have been reporting that, although they've been employed, the employers would always do this background check-in and then would identify that people have criminal records, and there's so much stigma attached to criminal records, and people have been struggling with unpaid wages, issues on financial hardship, and eventually leading to job loss due to these background checks. Women as easy targets for power abuse. So this particular one person was saying how she has been in prison for 20 times, but because she has this criminal record, she become an easy target for the police. So satu hari semasa nak pergi kerja, saya ditahan ketika roadblock. Saya dah 8 tahun bersih, 8 years not using drugs. My urine is clean, but I've been arrested with 39C. So this is increased penalties because this person has been in prison for so many times. So she's been sentenced to 39C, which means caning and 5 years of imprisonment. Walaupun saya lawan untuk hak saya dan saya menang, saya terpaksa remand 75 days without methadone, and it's and ia amat memerikkan. It's so the person was so much in pain without methadone. So it's the issues of repeated imprisonment, unjust arrest, just because someone has been in prison for so many times, and also what is causing interrupted methadone through these periods of engaging with the criminal justice system. The third case we want to highlight on transgender who use drugs. So highlighting on the lack of gender-specific services in the country. For instance, this person was saying, saya mahukan bantuan, she needs help for drug use, but there are no rehab centers that would want to be accepting of transgender because they would not know where to put me, whether in the women quarters or in the men's quarters. So these are stories that we hear on the ground that kind of reflect everyday challenges faced by people who use drugs when it's so much related to criminalization of drug use. So it kind of boils down to the importance of having social innovations in HIV treatment and services. It highlights the need for new creative solutions and also approaches that are more flexible, they're more inclusive to kind of overcome the barriers and to improve access to services. To look at how social innovation can actually offer a key solution to these barriers, we need to ask these different questions, these three important questions. How are services being delivered? Where are these services being delivered? Whether it's close to where people are or whether people need to travel far to access these services. And finally, who are actually delivering these services? So what we are aiming for to reduce health inequalities is to have low threshold services as compared to high threshold services, which can only be accessible to 20% of active users, as you can see in this diagram here. So having lower threshold services in place would mean to remove structural barriers. It's going down in this triangle, going down to the street where a lot of these communities are, and it's community-based because it's closer to the street drug scene. It allows people to get services on the same day. It allows optimal methadone doses, not too low and not too high. And finally, to make sure that waiting hours are reduced so that people do not have to wait too long to access these services. And what we have in Malaysia, for instance, in collaboration between the NGO, Insamuni Malaysia, and also the Malaysian Ministry of Health, is this model that is called the Cabin Harapan, which is physically located within the KL Health Clinic for easy referrals, and it's being maintained by community healthcare workers. And remember that one of the key points of social innovations is who are delivering these services. And you can see on the left-hand side of the photo, standing next to me is a peer worker whose job, as someone with shared experience, would be able to reach out to hidden populations, such as people who use drugs who we can't easily detect in the community. So having these people, it brings this strong sense of trust towards these peer workers that allows services to be successful. Um, Mobile programs is an example of what they have in New Haven, in the US. So mobile programs are being operated from a van or bus with needles and syringes distributed through a door or window. So it's also acting as a fixed sites with testing and other healthcare services, linkages to addiction treatment, linkages to other uh, medical needs. So having these buses to move around, it brings focus on harder to reach or smaller populations in the community, allowing people to access services better. So some key messages that I would like to highlight here. 6 key messages that I would like to bring to you is that human rights are definitely central to end AIDS. We would need to recognize the need to respect and protect human rights and how it is crucial for achieving the global HIV 95-95-95 goals. We want to advocate for policies that eliminate discrimination, stigma, and punitive laws against people living with HIV and key populations at risk of getting this disease. Addressing inequalities to achieve equity, we want to highlight how important it is to how important social, economic, and structural equalities that kind of fuel HIV epidemic, and we want to call for targeted efforts to remove these barriers, meaning that it's beyond the healthcare system to work on this, but it needs to expand to more diverse groups of key stakeholders, the police, people from the Ministry of Education. So we want to call for these targeted efforts to kind of remove barriers and to address inequalities to achieve equity. The third point, we want to be able to empower communities. So what the international community has called for is this strong need to have community-led responses, meaning that people from the community would need to design their own programs because these are the ones who know best, because these are the ones who have been experiencing the social and the legal environments that they are in. And we want to be able to support them by prioritizing the voices of people living with HIV and people who are affected by HIV. We want to promote grassroots advocacy to ensure that local needs and solutions are central to decision-making processes. And number 4, we want to improve access to comprehensive health and social services. So it's not just the health services that we're looking at, but we need to acknowledge that everyone has the right to affordable, high-quality healthcare. That is not just prevention and treatment services, but also looking at ways to support their social needs as well. Pushing for health coverage that leaves no one behind, challenging stigma and discrimination. I think number 5, there is so much that we need to do, especially in educating the general society to combat the stigma and prejudice that deter people from seeking care, even disclose their status. Legal and policy reforms, we want to advocate for the repeal of laws that criminalize HIV transmission, non-disclosure exposure, and supporting legal frameworks that protect key populations, especially those who are using drugs and those who are engaged in same-sex activities or even in sex work from abuse and discrimination. Before I end, I would like to take a moment to shamelessly advertise this talk on gender and human rights, where there's a focus on drugs and decriminalization, which I will be moderating on Friday, this Friday, 13 December at 4 p.m. Malaysian time. So I'd like to invite everyone to, if you have the chance to listen to this talk, to kind of join us for this Zoom webinar. With that, I would like to end my presentation. Thank you for listening.
Thank you very much, Dr. Ika, for your presentations. Okay, so we have a bit of time. I guess we can have about 2 to 3 questions. So open up to the floor. Let me have a look at the chat box. Is there any questions or not? Okay, I guess while waiting the question roll in, I have a question for Dr. Ika. So, what can academics like us do to ensure the rights of key population are protected?
So I think what's really important is first to acknowledge that academics come from different fields and it's not just a one-man show. We need to have people coming and working closely with us. So I think we can join forces. So I'd like to make use of this opportunity to call for people who are also interested in doing HIV research to reach out to us in the public health department or even through CHIRIA, the Center for Excellence for Research in AIDS, to see how we can work together in addressing some of the issues faced by key populations. I think that's number one. And second, I think there is an emerging trend where community-based organizations started their own initiatives in embarking in research projects, and I think one of the ways that academics can help support this initiative is by reaching out to these key populations, reaching out to these community-based organizations, and provide technical assistance in helping them in their own research and endeavors. Those are the two things that we can always work on as academics. Work together as academics, different diverse fields, and second, to work together with community-based organizations, even with the community members, to see what the needs are and to work something together with them in terms of research. And also helping them to make use of these research findings to advocate for better policies for people living in HIV.
Thank you very much, Dr. Ika, for your answer. I totally agree with you. There's no man as an island, and I like the idea about the data-driven policy in decision making. So I think it's really, really important. So everyone have to come together and work, and hopefully the numbers will tell more, and we can do more things from there to help these populations. Yeah. So, is there any questions? If not, then I guess I will make a closing remark before hand over to the next session. So thank you to all for your participation in today's Dr. Ika's webinar sessions. Together, we have explored the intersections of health, equity, and human rights in our fight against AIDS. So let us take what we have learned today and transform it into action, ensuring that no one is left behind on this path to ending the pandemic. So remember, every step we take together can make a difference. So thank you and have a nice day ahead. Thank you, Dr. Ika.